Hello, today's topic is intracellular accumulations under the chapter Cell Injury. So, metabolic derangements within cells lead to accumulation of abnormal amounts of substance, which can be normal or abnormal. And so, the substance accumulation can occur either within the cytoplasm, within the nucleus, or within various organelles. Most typically, it occurs in the lysosomes. And there are four main pathways associated with this. So, one is in which there is accumulation of a normal metabolite due to abnormal metabolism or packaging which occurs. A classic example of this is fatty liver. Next mechanism is in which an abnormal metabolite accumulates as a result of genetic defect in protein folding or protein transport. So, the abnormal protein is what accumulates. And next is in which failure to degrade a metabolite due to inherited lack of enzyme leads to accumulation of the product. So, this is what classically we know as storage disorders. This occurs due to inherited defect in an enzyme. Apart from this, the fourth mechanism is by which some of the phagocytosed particles such as carbon particles or silica are unable to be digested, and so they accumulate within the cell. So, these are the four mechanisms by which substances accumulate within the cell. So, first we start with lipids. So, lipids, any type of lipids such as cholesterol, triglycerides and even phospholipids can accumulate within the cell. But among these, steatosis, that is fatty change, most commonly refers to the accumulation of triglycerides within the parenchymal cells. The most common site of steatosis is within the liver. And apart from this, in heart, muscle and kidney also fatty change can be seen. So, this is an example of a diagram showing fatty liver, steatosis within the liver. So, the special stains used to demonstrate lipid, this is very important. Oil redo, Sudan black and osmium tetroxide, these are the special stains used to demonstrate lipid. Next is cholesterol and cholesterol esters. So, these can accumulate in the following conditions. One is atherosclerosis. Atherosclerosis in which the cholesterol-laden macrophages are seen in the vessels, the intima layer of the vessels such as the aorta and other large arteries, that is atherosclerosis. Apart from that, xanthoma refers to the subcutaneous tissue in which cholesterol-laden macrophages are seen. And apart from this, Niemann-Pick disease is in which cholesterol-laden macrophages are seen in a variety of organs within the body. And the fourth example is cholesterolosis. What is cholesterolosis? This can be asked as a question. A cholecystectomy specimen is given and the biopsy of the slide and you have to diagnose. So, here beneath the epithelium, you can see many cholesterol-laden macrophages within the lamina propria of the gallbladder. So, this is an example of gallbladder cholesterolosis. Next is protein. After lipid, we see protein accumulation. See, this can occur intracellularly, which are seen as rounded eosinophilic droplets, or it can occur in some disorders such as amyloidosis. Amyloid protein can occur as accumulations extracellularly also. So, these are the various causes of protein accumulation. One is accumulation of a normal secreted protein which is produced in excessive amounts. A classic example of this is Russell bodies. The Russell bodies are seen in plasma cell disorders. Plasma cell disorders are where Russell bodies are seen, and this occurs as distension within the endoplasmic reticulum. So, these are seen as Russell bodies. Apart from this, defective intracellular transport, example is alpha-1 antitrypsin deficiency. And third is accumulation of cytoskeletal proteins such as occurs in Alzheimer's disease. Here what happens is that neurofilaments Neurofilaments are a type of cytoskeletal proteins which accumulate in case of Alzheimer's disease, leading to dementia. Third is aggregation of fourth is aggregation of abnormal proteins. This occurs in amyloidosis. And finally, there is also in cases of heavy proteinuria. In heavy proteinuria, what happens is in the glomerular apparatus, there occurs reabsorption of droplets in the proximal renal tubules, which are seen as pink hyaline, rounded pink hyaline droplets. So this is also an example of accumulation of proteins. This can also be asked as a question. See, an elderly male or female with multiple lytic lesions of the bone, and this is the bone marrow aspirate picture, and you've been asked to diagnose. So here what happens is that in the cell there are multiple Russell bodies seen. So this is a case of myeloma showing multiple Russell bodies and grape-like clusters are seen. These grape-like clusters is what is called a Mott cell. So this is a case of multiple myeloma. The next is glycogen. So glycogen accumulation occurs as a result of abnormal glucose or glycogen metabolism. So this is seen in histopathological slides as intracellular clear vacuoles. So the ideal fixative, when you bring a specimen for demonstrating glycogen, you need to bring the specimen in absolute alcohol. Normally, we bring specimens fixed in formalin. That is a normal fixative used in all routine specimens. But in order to demonstrate glycogen, you cannot use formalin because it will dissolve out the glycogen and you won't be able to demonstrate it in the slide. So in order to demonstrate glycogen, absolute alcohol is the ideal fixative. And the special stain used is PAS stain. So this is a case of glycogenic hepatopathy in which the hepatocytes appear pale because of glycogen accumulation. Next is pigments. What are pigments? Pigments are actually colored substances. These can be either exogenous, that is produced outside the body and getting in, or it can also be endogenous. Endogenous is synthesized within the body. So examples of exogenous pigment, most common is carbon. See, in coal miners, what happens is inhalation of carbon dust over a prolonged time leads to an interstitial lung disease known as coal workers pneumoconiosis. And another example is tattooing. Tattooing is a form of localized pigmentation of the skin, and so it is seen as pigment-laden macrophages beneath the skin tissue. So moving on to endogenous pigments. One classic example is lipofuscin or lipochrome. So how does lipochrome pigment form? It occurs as a result of lipid peroxidation due to the free radicals. Free radicals cause lipid peroxidation of the plasma membrane. Thus leads to formation of complex composed of lipid and phospholipids which complex with proteins, and this is called lipochrome pigment. So it is also known as wear and tear pigment or the aging pigment, and it is a sign of free radical injury and lipid peroxidation which has occurred. This is associated with cellular and tissue atrophy. This is an important question. Which is a pigment associated with brown atrophy? That is lipochrome. So it is seen mainly in aging, especially in the liver and the heart, and in cases of severe malnutrition and cancer cachexia. See in this diagram a section from the cardiac myocytes showing aging, and this is what is seen as lipochrome pigment, yellowish brown pigment situated in the cytoplasmic or the perinuclear location. That is how lipochrome pigment is usually seen. Next endogenous pigment is melanin. Melanin is an endogenous brown-black pigment. It is derived from tyrosine. And this is important. It is detected using Masson-Fontana staining. Masson-Fontana staining is a stain used to detect melanin. This is a case of melanoma of the skin. What all you see here are all tumor cells. Tumor cells composed of large pleomorphic cells with hyperchromatic nuclei. And you can see many of the tumor cells, and even outside there is melanin pigment accumulation. Next endogenous pigment is homogentisic acid. This is also a black pigment. Mainly the deposition is seen in case of a rare metabolic disorder called alkaptonuria. Alkaptonuria is where you see homogentisic acid. And in alkaptonuria, ochronosis is the name given to accumulation of this pigment in the skin, connective tissue and the cartilage. Next is hemosiderin. Hemosiderin is actually a pigment derived from hemoglobin. It is also golden yellow brown in color, and the hemosiderin is actually composed of aggregates of ferritin molecules. So this is the major storage form of iron, and this is very important. This stain used to demonstrate hemosiderin is Pearl's Prussian blue stain. So this is Pearl's Prussian blue stain showing deposition of hemosiderin. So this, the clinical relevance is that it can be used to demonstrate iron in the liver or in the bone marrow. So we end with a question. A deceased, poorly controlled diabetic. At the time of autopsy, his kidneys are noted to be pale, and the vitreous, that is the eye vitreous electrolyte analysis indicates a vitreous glucose level of 576 mg per deciliter, and acetone is detected in the blood. A diagnosis of diabetic ketoacidosis is made. Microscopic examination of the kidneys reveals small clear vacuoles in the renal tubular epithelial cells. Of the following, which is the most likely content of these vacuoles? The main features to note that it is an uncontrolled diabetic, and at autopsy the kidneys are pale, and diabetic ketoacidosis has been diagnosed, and small clear vacuoles are seen in microscopy. So small clear vacuoles means it rules out lipofuscin, it rules out hemosiderin. These are brown in color. It rules out carbon. This is black in color. So between triglycerides and glycogen, what we have to remember is that during diabetic ketoacidosis, it eventually leads to accumulation of glycogen within the cell. So glycogen is the answer. Thank you.